let's see what's next. We have a 16-year-old boy with a skin-colored papule on the scalp. So you can see a nice punch here that has really gone right around the lesion. It does go focally to the edge, but they got the majority of the lesion. Let me show you this one first. And going in closer, there's two different things here, okay? Number one is what's happening at the periphery, and the second thing is what's going on in the middle. So let me show you the edges first. This looks like, to me, a regular conventional nevus, maybe congenital type, right? Small nevoid melanocytes that are kind of trickling as they go down deeper. There's more over here. So, to me, a regular benign nevus that I would see any day. But in the middle, we have a more cellular nodule, and it's composed of cells that are much larger. They have round nuclei that are bigger. Some of them there's some scattered pleomorphic cells. Not diffuse pleomorphism, but there are scattered large cells. The cells have abundant cytoplasm, and many of them, as single or maybe double cells, are wrapped around by a little layer of collagen. They're kind of encased in their own little cocoon of collagen. So, and the cells are much more cellular in the middle. Looking around, though, mitotic activity, to my recollection, was very low for this case. So when we see a lesion that has, looks like a nevus, but has two different components, one thing to think of is a combined nevus or a combined melanocytic lesion, where you have two different patterns of nevus or melanocytic proliferation arising in the same area. The other thing that I always worry about is, could it be melanoma growing out of a background nevus, a melanoma arising in a nevus? So to me, that's always my concern. This was a young patient, a teenage patient, possible to have melanoma at that age, but very rare, I think, overall. The other thing, somewhat reassuring, is nothing in the epidermis that looks like melanoma. Now, that's not perfect, right? We do know that you can sometimes have melanoma without an obvious in situ component, but that's one thing that I think about is, do I see anything in the epidermis that makes me concerned? Pagetoid spread, confluent growth, things like that. So I had an idea here, and I did a stain, and I will show you. Oh, there's more of the cytology. And here. And what stain is this? Does anyone know? Yeah, BAP1, BRCA-associated protein 1, BAP1. So this is something that I think Dr. Wiesner was one of the first to start writing about this, and others have. And the idea of these is that these are lesions that have loss of nuclear BAP1 staining. So BAP1 is present in many of the nuclei of normal cells in the body, including the nuclei of normal conventional nevi. But in these lesions, you have a component of the lesion. Usually there's a background regular nevus, and then a zone of larger, more epithelioid cells that have loss of BAP1 staining. And you can see real clearly here that the nevus, the conventional nevus at the edges, retains the nuclear staining, and these cells in the middle, it's lost very cleanly, right? As with any immunostain where being negative is meaningful, right? Most immunostains are, when they're brown, they're positive. But a stain where it's lost, you have to be very careful to make sure your internal control works, right? Just like the microsatellite instability stains, or INI1, SMART-B1, or BAP1. You have to make sure your internal control stained well. So here, those are the nevus cells, and then here is the central area, okay? So these have been called by a variety of names. The name I kind of like, even though it's not official or proper, is BAPoma. It's the BAP tumor, right? And I know it's not proper. And look, Arno's like, he's weeping in the corner there. But when I talk about them to my colleagues, I say BAPoma, everyone understands what we mean. Now, I don't call it that in my report. But I actually have struggled a little bit with what do I call these in a report, because the literature has used a variety of different names over time for these, okay? So the question, first of all, is, well, what are they? So what happens here is that, and again, I think the WHO book has a very nice explanation of the general molecular ideas behind nevi and melanocytic neoplasms. And I've also given you some references here that talk about this entity. But the idea is that, regular nevi usually have an inciting mutation that causes them. And in this case, in these lesions, usually it's a BRAF, V600E, I think is the most common mutation that causes the regular nevus that's in the background. And then a second phenomenon happens where BAP1 is lost in this central proliferating kind of area of more enlarged epithelioid cells. And this can happen in two settings. It can be sporadically in normal individuals in which they've had knockout of both copies of the BAP1 gene, the one on both of their chromosomes. But there are also people that have loss of BAP1 as a germline abnormality, where they are missing one copy of BAP1. And in those patients, they only require one hit to knock out BAP, okay? The reason that's important to know is that patients that have germline BAP1 abnormality are at risk for a variety of different tumors. Uveal melanomas, they're at risk for mesotheliomas potentially, and others, right? So we know it's basically a cancer-associated syndrome related to BAP1. So this lesion potentially serves as a marker of patients with those syndromes. And my understanding is that when you see these, about 10 or 15% of them are going to be associated with the syndrome, but the majority are just incidental, sporadic lesions in otherwise normal individuals. And pretty much all the data that I've read on it, these are going to probably behave in a benign fashion, although it is possible to have melanomas with loss of BAP1. All the ones that I've seen so far, to my knowledge, behaved well. I still have recommended complete excision with negative margins, and I've recommended the patients see a genetic counselor to discuss the pros and cons of germline testing for BAP1. My understanding is that the patients that have the syndrome, the germline BAP1 loss, they often get multiple lesions that look like this. So I also think of that because some people have pointed out that these have a somewhat spitzoid appearance. Molecularly, they are not spitz nevi. But some people early on had suggested they look kind of like spitz nevi. I think the nuclei are different, but the fact that they are large, plump cells with abundant cytoplasm, I think does call to mind or resemble to some extent, superficially resembles spitz nevus. And so whenever I hear a person with a history of multiple atypical spitz nevi, I instantly stop and think, I wonder if they really have a BAP1 loss lesion. Because it's been around maybe 10 years or so, but I think it's still not widely recognized outside of dermatopathology. And so many lesions probably that have been classified in the past as an atypical spitzoid lesion may have been these. And yet maybe at the time people were unaware of the diagnosis. So this patient thankfully had genetic counseling, and germline testing was negative. This was just a incidental lesion, and as far as I know, had an excision with negative margins, and follow-up has been good so far. So I had the pleasure to get to meet with the family of this patient and talk with them about it, and it was a really great experience to do that. So be on the lookout when you see this large nodule. In this case, I was a little concerned, even though I saw the BAP1 loss. I wasn't sure, like, what do I do about these big nuclei? Is this too much? Do I need to worry? And I sent it off for consultation to melanocytic experts, and they said, no, this is BAP1 nevus or melanocytoma. So that's the next thing we'll talk about. And again, I told you the afternoon was going to get harder. You have that postprandial somnolence, right, from eating the lunch. And then I'm talking about all this esoteric, rare, confusing stuff that I still struggle with. So this is how I feel in the afternoon. Usually these cases, I say, tomorrow, demain, in the morning. But today we have to do it in the afternoon, okay? If I would have done it this morning, though, you would not have come back after lunch. You would have gone home. So I had to trick you and lull you into, this is good. And now you're back. Doors are locked. I'm not going anywhere. Good crowd. Thank you for the laughs. It gives me some energy. So I wondered, in the WHO, it talks about that it includes this category under the combined nevus or melanocytoma category. So what is a melanocytoma? Well, I like the WHO has said it one way, and I also, my friends at UCSF, University of California, San Francisco, they had a little comment in their report that says, that melanocytoma basically is a lesion that has, more abnormality, particularly genetic abnormality, than a regular nevus, but it doesn't have features sufficient to make a diagnosis of melanoma. So it's kind of in the gray zone. And I kind of like it because it standardizes the terminology we use for these lesions that don't fit neatly into benign or malignant. In the old days, some people said, well, there's no such thing as gray lesions, only gray pathologists, right? That you should be black and white, and it's not the lesion's problem, it's your problem. But I don't believe that, and I think molecular is proving that that's maybe not true. We make boxes because it's so comfortable and convenient, isn't it? When I take it and I drop that tumor right into the box and it fits perfectly, well, it doesn't always do that. The tumors don't read the textbooks that we make for them, right? They do what they want. And we have to find a way to deal with the ones that don't fit in the boxes. And it's a struggle for me all the time. So the WHO, for all the things I like about it, I didn't feel like reading the chapter on this gives a clear answer of when to call it nevus and when to call it melanocytoma. They kind of say nevus/melanocytoma. So I've struggled with this, and I wonder, and I'm really curious to hear how your approach is. But when I sent this off, it came back from the experts as BAP1-inactivated nevus, open parentheses, BAP1-inactivated melanocytoma. So even the experts, I think, struggle maybe of where exactly to put these. I usually say nevus/melanocytoma, say that the prognosis is probably very good, but that you should excise it with negative margins. And I've not yet seen one that was frankly malignant, but I am really curious to hear input from a true expert here, because I am just a novice trying my best to make it through each day. So, Dr. de la Fouchaudière, would you can come up here, come to the proper mic. And I was very nervous and then I was tweeting about coming here, and Arnaud's like, oh, I'll come. And I was like, oh gosh, I've got a couple entities that are like his thing. So I usually talk about soft tissue because I know about soft tissue tumors usually more than most people in the audience. But when you have an expert in the audience, is the nerves a little bit more.
So
please teach me.
What should we start with? The melanocytoma. So you have to understand that in the concept of the WHO, melanocytoma is just a category that is between the progression model from nevus to melanoma, and we put two intermediate steps. So in the BAP1 group, the first step would be just the BRAF mutated nevus, and then the second step, which is a low-grade melanocytoma, is the BAP1-inactivated nevus. This is a perfect example, and what you have, low mitotic activity, and usually I use proliferation rate is under 5%. Okay. And also you see there's no hyperdensity, and for me the main differential is I agree, nevoid melanoma ex nevus, so that's what you want to rule out. And then the third step is the high-grade melanocytoma, and these will have these are rare, and I have cases that go to, I have seen more than 20 cases that go to melanoma. And what is interesting is I have really the luck to find cases that have on the same slide the 4 different stages for BAP1 or for DPN, and I've shown this, and I should make videos.
I was going to say, I want this video.
So, and you really see the progression from the nevus, the typical, the low-grade melanocytoma, the high-grade, which gets higher density and less cytoplasm and more nuclear atypia. And then you see the really malignant with the mitotic activity, and you even see it on the CGH with the clonal. So this is the clonal disease.
Okay.
So what else was?
Yeah, so you have seen some where they are
Yes.
progressing all the way to malignancy.
And to become metastatic.
Wow.
But I know there are very few reports, and this is a paper I should be writing. I have more than 300 cases of BAP1 inactivated tumors, and among them are
See? I told you.
more than 20 are really malignant cases, and some are metastatic.
I think I've seen 10, maybe, in a decade. So, yeah. No, that's awesome. Thank you so much. This is the ultimate crowdsourcing here. I was like, oh, I'll make him give the lecture. And that worked out pretty well. I learned. Thank you very much. I truly appreciate that. Merci beaucoup. I would love to see that video, actually. That would be amazing. Because I think this is something, as you read the literature, there is still, I think, confusion is not clear or widely understood clearly by regular folks like me trying to diagnose, like how to approach these, when to worry. Do you routinely recommend genetic counseling or germline testing?
Yes.
Okay.
Systematically. And I mostly recommend if the patient had another dermal nevi removed to have it tested by IAP.
So Arnaud said that he routinely does recommend for the patients to have genetic counseling or genetic testing to see if they have germline BAP1 abnormality, and also that if they've had other nevi removed, even if they were just called regular nevus, maybe to consider doing BAP1 immunostain to see if there was loss in those lesions. Because it would be, if they have more than one lesion with BAP1 loss, then they almost certainly are germline, right? Okay. Really, really amazing. So so these are things to be on the lookout for, because they look really scary and a lot of complicated issues to deal with. And do you have genetic counselors in France? Is it a field here?
Yes.
So I really like it, to go on a side note, in general, when dealing with complicated molecular syndromic type abnormalities, I love recommending patients to see, not just have the test done, but see a genetic counselor, because there's a lot of complicated issues that go into molecular testing, especially when you're testing for something germline, because you're not just testing that patient. Your test applies to their kids. And whether or not, if they're young, if they decide to have children, family planning, there are a lot of issues that become very important ethical issues. If the person's a child, do they really understand the implications of having that knowledge about their own molecular abnormality and what that might mean for their future decisions? I may think I know what I would want to do if it were me, but I don't necessarily know other people's values or how they will do it. So I feel like genetic counselors deal with that complicated discussion on a daily basis. And I think it's important as pathologists, we understand that you have to understand what question you're asking when you do a test. And you also have to understand what you're going to do with the answer to that question. If you just do a test and you're like, oh, well, now it's positive, now what? That's a problem. So I think that having these discussions ahead of time helps to avoid those complications. And I've routinely I had a genetic counselor call me up a while ago and say, I saw that you recommended a referral to genetic counseling in your path report. I've never seen that before. That's really cool. And I was like, you guys are doing amazing stuff. And it really, I think, makes a really important contribution to patient care. Because again, we get focused a lot of times on metastasis and death from disease. But there's a lot that has to do with anxiety and patients worrying every day. Am I going to be alive to take care of my kids in a few years? Are my kids going to get this tumor that I have? I work with these rare cancer groups. That's what these people worry about. They worry about what their next scan will show, or will my child get dermatofibrosarcoma, or which of course, no, they won't, because it's not germline. But they just understand DNA problem, right? So I think there's a huge problem with lack of knowledge and education of patients. And having seen the suffering mentally and emotionally that some of these patients go through, information is a simple, free way for us to fix some of that problem. It doesn't fix everything. So I feel like as pathologists, we can be the gatekeepers there, and we can see that there's a problem ahead of time and recommend those patients get to the proper treating doctor, the proper team to take care of them. Same for like neurofibromatosis. They need someone who pulls all the info together, and neurofibromatosis involves lots of different organ systems. I think genetic counselors play an important role there too, because it's such a complicated disease. Or no?
I worked with counselors to write how to write it in my report.
Oh.
They helped me. So it was together that we worked the way to make a formula that would fit everyone.
So Arnaud is just saying, it's beautiful. it's amazing. He said he worked with the genetic counselors to come up with the proper language to use in the comment of his report that is the best approach and the best comment that helps everybody. I would love, if you're willing to share, I would love to get a copy of that and see how you word it. You know, a true master of BAPoma, if you'll forgive my very slang street name. Okay. Well, anyway, thank you for indulging me. But it's a topic I feel very passionately about, and I think pathologists, we're often looked at as people that just do autopsies or hang out in the laboratory, but we actually have an enormously important role to play in patient care. And sometimes we're the last line to stand up and help avoid a problem from happening to a patient. And if we can do that, then I can say I've done my good deed for the day, and I can go home and sleep well that night. All right.
There was a question.
Oh, a question? Yes.
If the patient was older,
Would you? Oh, I don't know. So I'll let R know. If the patient was older, would you perform the BAP1 stain or think of nevoid melanoma?
It can start in children, but you can have it at 80-year-old.
Oh, okay. So it can happen at any age. So still worth doing even in older patients. Yeah, and I think with genetic things, I know it is often more problematic for young people, but if in older adults maybe already have children or grandchildren, there are times where germline things, may be meaningful for other living relatives to know about potentially.
And also, there's almost a systematic pattern of P16 expression in the BAP1-inactivated tumors. And in nevoid melanoma, it can be completely lost or clonally lost. And you never almost find it in the BAP1-inactivated nevus.
So you see P16, what does it look like?
Would basically exclude a diagnosis of BAP1-inactivated nevus.
So do you see patchy P16 or is diffusely positive?
No, it's heterogeneous but stronger than in the background.
Oh, then the background nevus.
Yes.
Okay, so I know this is now Arnaud's lecture here. We'll have to, no, please don't. I'm apologizing for my lack of knowledge. You guys have me here as the expert speaker, and I'm like, well, it's good for us to know there's always people that know more than what we know. And I've learned a lot. This is wonderful. So he was saying that you will see a subset of the cells will stain in the BAP1 lost area. It will be some positive, some negative, heterogeneous, but stronger intensity than in the background nevus and not diffuse loss, right? Diffuse loss is a strong argument against a BAP1-inactivated nevus or melanocytoma. Wonderful. Thank you very much. Yes? I don't know. Do they both express melanocytic markers the same way, like MART1, SOX10? I don't know if I've done it before. I don't remember. Because usually when I see it, if I recognize it, I think, oh, BAP1, and then do that. Occasionally, I guess I've done other markers, but I don't remember ever seeing a difference in MART1.
MART1, it can be maybe weaker than in the background.
It could be weaker MART1 in the BAP1 loss?
It's rare to have, it can have focal HMB45.
Focal HMB45. Okay. Cool. Great question. Well, I just went to school. All right. Thank you. That was really great. I learned a lot.